So, good morning, and thank you for joining us. My name is Kirsten Vivens Domingo. I am the chair of the Department of Epidemiology and Biostatistics at UCSF, and I'm also the vice dean for Population Health and Health Equity in the UCSF School of Medicine. I'm really pleased this morning to moderate this grand round that's put on by our new Sampling Knowledge Hub in the Department of Epidemiology and Biostatistics. We're launching, this is the first event for this hub that has launched this year. And as far as we know, our hub is the first of its kind to really dedicate to improving researchers' understanding of sampling, which forms the basis for so much of our biomedical research. The hub is led by my colleagues who are our panelists today, all of whom are experts in the truly cutting-edge sampling methodologies. Today, they are applying their expertise to sampling for COVID-19 antibodies to help us understand some of the research that's coming out that's really critical to managing this important pandemic. We're also delighted to have a special guest today, Professor Karen Byrne, who's a professor in epidemiology and biostatistics, will also walk us through the important question of how test accuracy affects our interpretation of seroprevalence study results. I will be your moderator this morning. Please use the Q&A function. We've disabled the chat function, so use the Q&A on your Zoom screen. We will address all of the questions at the very end, and we're scheduled to go for 90 minutes, so till 11 o'clock today. Our panelists today are Yehung Chen, who is a research and data specialist in the Prevention and Public Health Group. He has experience in studying HIV-related risk behaviors and HIV transmission among hard-to-reach populations. Jean Digitale is a pediatric nurse and a second-year PhD student in our department. Maria Glimor is the program director of our PhD program and a leader nationally in overcoming methodologic problems encountered in analyses of social determinants of health, Alzheimer's disease, and dementia. Tom Hoffman is an associate professor in our department. He is a biostatistician whose main research interest is in human genetics. He is also the lead statistical consultant for the UCSF School of Medicine. Megan Morris is an assistant professor of epidemiology and biostatistics who focuses on infectious diseases in hard-to-reach populations. Paul Wesson is also an assistant professor in epidemiology and biostatistics, and his research seeks to quantify health disparities among hard-to-reach and socially marginalized populations, particularly as they relate to infectious diseases. And as I mentioned, we're delighted to have Karen Byrne join us today. She's a medical epidemiologist who works on Chagas disease and visceral leishmaniasis. Thank you, and I'm going to turn it over to Megan to guide us through this discussion today.
Thank you, Kirsten. I am really pleased to have this opportunity to have the discussion this morning. And I just wanted to say good morning to everyone who's in attendance. Next slide, please. So since the early weeks of the COVID-19 pandemic, we primarily relied on confirmed or probable case data to understand disease burden. Early confirmed case counts needed to be interpreted with caution, as estimates were derived from hospital-based samples representing people with more severe disease and people engaged in the medical system. Confirmed and probable case data, next slide, please. Confirmed and probable case data provide a limited view of the actual population experiencing COVID-19 disease. Seroprevalence data describe information about the proportion of the population who has been previously infected. Combined with confirmed case data, these offer a more complete snapshot of the disease epidemic. Next. In April 2020 represented an important shift in our COVID-19 data infrastructure as testing availability increased and more test platforms came onto market. Active infection is diagnosed with PCR-based tests and does not provide information on past infection. Antibodies can be found in the blood of people who were tested after infection. And antibody test results are especially important for detecting previous infections with few or no symptoms. In the month of April, new serology-based antibody tests came onto the market, generating excitement about the ability to conduct antibody testing outside of the clinical setting. Dr. Byrne will share some updates on the FDA's response to the antibody test revolution later this morning. And it's important to note that, accuracy aside, the technology moved the conversation about conducting community-based studies of prevalence from intention to action. Next slide. Uncertainty can be introduced to any estimate through both measurement error and sampling error. This morning's talk will discuss core concepts of sampling methods to illustrate sources and impact of measurement and sampling error as it relates to seroprevalence estimates. Next. So let's take a step back. When you hear the term sample, what do you think? Who do you think it represents? In an ideal scenario, population health indicators, such as seroprevalence estimates, represent a parameter reflecting what is really happening. We employ sampling methods to increase the validity of these estimates, and sampling allows us to conduct research more efficiently and cost effectively than sampling everyone in the entire population. The study sample is a group of people who we actually collect data from and provides the data used to calculate these estimates. The sample is a subset of the actual population. The collection of people that would have made it into the study on the basis of meeting eligibility requirements had they have been selected and were willing to participate. The target population is the broader group that we've sampled from and about which we aim to make inferences. The target population is defined by the investigator based on a priori decisions to set a population boundary. The external population is an even broader population to which the investigator may want to generalize these estimates. There may be more than one external population that the investigator wants to be able to generalize estimates to. The basic idea behind sampling is that we can generalize to the population based on a smaller subset, the sample. Today, Drs. Wesson and Chen will discuss how applying a sampling frame can minimize the amount of sampling error. Next. Today's talk uses the recent COVID-19 seroprevalence studies as an example to demonstrate key sampling concepts. As mentioned earlier, the changes in serology test availability opens new opportunities for the type of data that we can collect. It also introduces new opportunities for where seroprevalence research can be carried out. The history of HIV and hepatitis C seroprevalence research offers an interesting lesson in how seroprevalence estimates can be derived from a sample representing a diverse set of groups. Groups traditionally not engaged in research. Many factors led to these successes in HIV and hepatitis C seroprevalence research. One factor is having a serology test that can easily be administered by study staff and processed quickly. This was an important tool allowing public health researchers to design and implement studies in partnership with community collaborators. Next. As we wait for antibody testing technology to develop further and allow accurate rapid serology testing like those that we now have for HIV and hepatitis C, I hope that the conversation can remain focused on the goal of achieving study samples that reflect a diverse population. It is imperative for the subgroup evaluation and identifying disparities in COVID disease. Next. Because if we are relying on estimates from non-representative samples, our policy response will only increase these disparities, as research findings inform how and when we respond, and also which groups receive these responses. Next. Today, our team applies key concepts and sampling methods to recently conducted community-based COVID-19 seroprevalence studies. being equipped with knowledge about different sampling methods, their strengths and limitations, and how to address selection error during analysis can improve the quality of research findings independent of the topic area, which is really why we're really excited as members of the new Epidemiology and Biostatistics Sampling Hub here at UCSF to share these concepts today grounded in the COVID-19 pandemic examples, because they really relate to all of the research that we're conducting. I'm pleased to turn it over to Dr. Huffman, who's going to provide an overview of a highly profiled seroprevalence study from Santa Clara County. Thank you.
Thanks, Megan. So I'll present some of the design and results, and you'll hear critiques from the rest of our speakers as we move along today. Thanks. So there were two versions of this that have come out. I think the first one received a bit more press, and then it's gone through some substantial modifications through a second release. So a bit about the methods of how the samples were recruited into the study itself. So advertisements were placed on Facebook, targeting a representative population of the county by zip code, and using specially targeted ads to balance the sample for underrepresented zip codes. However, as the study went along, they noticed, it's a 24-hour study, but as the study went on, they noticed that some zip codes or regions were being overrepresented for participants from wealthier zip codes. And so they actually moved, while the study was running, to preferentially accepting registrations from underrepresented zip codes. And over a matter of 24-hour period, they registered a total of 3,285 adults, and each of these adults was allowed to bring one child from the same household, and that was a total of 889 children. And the final sample itself consisted of 3,330 people that passed QC measures. And as will be discussed by Paul a bit later, this deviated from county demographics. And so the testing itself was done through drive-through sites. And they set these up in 3 different locations, and again, kind of in this 24-hour period in early April. And they ran an antibody test. It wasn't FDA approved, but at the time none were, by Premier Biotechnology or Premier Biotech. So they've talked a bit about the sensitivity and specificity of this particular test kit, with some information in their early draft and then quite a bit more information in their later draft, potentially addressing some concerns that people had. And so the specificity of the test is kind of the idea that the negative test really is a negative test. And when you think of how you're actually designing these studies, you want to have a nice high specificity to make sure you're not missing cases. The earlier paper had an estimate of about 99.5%, with a confidence interval that surrounded about 98.3% to 99.9%. And this means that the false positive rate could have been up to 1.7%, and that's relevant to some things we'll see in a moment. However, their updated paper, and that was based on about 30 locally tested samples and a little under 400 from the manufacturer. And in the updated results, they managed to get a lot more information from additional hospitals and other areas, where they brought this up to closer to 3,000. So they have a much tighter estimate of the specificity. And the sensitivity, or the idea that a true test, the positive test is really a positive test, had estimates around 80%. With a bit of a wideband confidence interval on it. They had about 30 from locally known and 85 from manufacturer in the first set, and they got another 35 in the second set. And so they estimated this prevalence in 3 different ways. The first is this raw frequency that Megan talked about earlier, where it's just the number that tested positive over the number of people that were tested. And then they went ahead and corrected this by the demographics. So they weighted by the demographics to get a more representative estimate representing the entire county. So they weighted it by zip code, sex, and race and ethnicity. And then finally, they provided an estimate where they're accounting for this, the sensitivity and specificity and the imperfect diagnostics of the test itself. And they provided a bit more of an update to further improve it in terms of the methodology in the later draft. And so the results they had, the raw results were that 50 of the 325 tested positive, or about 1.5%. And then, with a bit of a confidence interval there. And then they, from weighting it by, from using the population demographics to, come up with a little bit, more representative estimate, it increased to 2.81%, which, might, if you remember how it was originally sampled, they had sort of this influx of one particular demographic, and then later on they tried to compensate, but it might reflect some of that. And finally, they gave a weighted sensitivity specificity adjusted results, which might have been what you heard about from 3 different methods of calculating this, just because of the different groups that calculated this, whether it was just the Stanford, the manufacturer, or the combined estimate of both of them. They dropped that from their later one, in part because I think they probably had a larger number of samples and sensitivity, but their final updated results, again, after they've gotten a lot more information on the sensitivity and specificity of the test, was around 1.2% with a confidence interval 0.7 of 1.8%. And so this implies that there are maybe 23,000 cases with a wide confidence interval, around 14,000 to 35,000 cases. And then just additionally adjusting for the population weights, giving kind of their final estimate of about 2.8% with a range of 1.3% to 4.7%, implying that they're about, a range of between 25,000 to 91,000 cases, 95% confidence interval. So ending up with a higher estimate, much higher estimate, as we probably expect, than the 1,000 confirmed cases at the time. And so I'll turn this over to Paul, who will talk about, who critiqued the study.
Thank you, Tom. The Santa Clara study was motivated by the fact that the extent of under-ascertainment of infections is unknown. This is the denominator problem. A valid denominator is not available to estimate parameters like the fatality rate, which is calculated as the number of deaths divided by the total number of infections. The extent of under-ascertainment of cases is difficult to quantify because cases have been diagnosed with PCR-based tests, which provides information on active infections and not infections that have resolved. An additional limitation is that the majority of cases tested early in the course of the epidemic have been acutely ill and highly symptomatic, which misses people who were asymptomatic or had mild symptoms. Therefore, the objective of the Santa Clara study was to measure seroprevalence of antibodies to SARS-CoV-2 in a community sample drawn from Santa Clara County. Next slide, please. So Megan already went into detail on the hierarchy of populations, so I won't go into much depth on this, but I just want to present this just to provide a framework that epidemiologists use when thinking about how to sample a population and how to draw inference to a population. One of my mentors once told me that sampling theory is one of the greatest scientific contributions of the 20th century. And as Megan mentioned, the basic idea behind sampling is that we can generalize to an entire population based on a smaller subset, which is the sample. But this is not magic, and basic principles must still be followed. As Megan mentioned, we have the study population, which are the people that we actually sampled and collected data on. This is a subset of the actual population, who are the people who would be eligible for the study and would have participated had they been contacted. And this is a subset of the target population, which is the somewhat more theoretical population that we're actually interested in drawing inference from. The link between the study sample and the target population is internal validity. Here we're trying to confirm that our study sample is actually representative of the target population. Next, please. And an external validity refers to how well the study sample can generalize to some other external population, perhaps beyond the target population. But throughout all of this, we must ask ourselves, to whom does our sample actually refer? Just to again go over some of the details that Tom provided, 3,330 adults and children were recruited into the study. These were people who were residing in Santa Clara County. They were recruited through targeted advertisements on Facebook. These ads aimed at a representative population of the county by zip code, and especially targeted the ads are especially targeted to balance the sample for underrepresented zip codes. Now this is a convenient sample, which is a non-probability based method to recruit a group of people who are easy to contact or reach. And the benefits of this style of recruitment, or specifically this Facebook approach to recruitment, is that they were able to reach a large number of residents pretty quickly. And there was also granular targeting by zip code and socio-demographic characteristics. However, unbeknownst to the researchers, the lead investigator's wife had also sent an email to the listserv for a local junior high school in Los Altos advertising the study and falsely claiming that the antibody test was FDA approved and would indicate if participants were immune to COVID-19. Next slide, please. Here I will just go over some of the sampling results. So using census data from the American Community Survey, the investigators could compare their sample demographics to the demographics of the county. In this slide, we highlight some of the sample characteristics compared to the demographic characteristics of the county, as well as the results of their approach to reweight or adjust the sample to better reflect the county population. The sample reweighted the investigators reweighted the sample to reflect the sex and race proportions within zip code, again using data from the American Community Survey. You see here that while the sex and race characteristics of the crude sample are not reflective of the county demographics, after adjustment, they were a much closer match, which is not surprising because sex and race were 2 of the 3 variables used to estimate weights. Next, please. However, the age distribution, on the other hand, does not reflect the county age distribution even after adjustment. Next slide, please. Here we show the distribution of participants with respect to zip codes within the county, both in terms of the absolute count on the left and a standardized participant rate per 1,000 residents by zip code on the right. This is another indication that geographically, the sample was not representative of the county, but rather study participation was concentrated in a few zip codes. Again, this is not surprising considering that there were 3 testing locations situated in Mountain View, just south of Palo Alto, Los Gatos, just south of San Jose, and San Jose itself. Next slide, please. Let's refer back to the hierarchy of populations framework, but this time filled in with information that we actually know now from how the study was designed and carried out. Next, please. So the target population, we can say, refers to Santa Clara County residents. The actual population, next please, refers to residents exposed to the Facebook advertisement and the email to the Los Gatos Junior High School. And the study sample were people with the means and the availability to actually show up to the testing sites. And again, we ask, to whom does this sample refer? Next slide, please. Using the Santa Clara study as an example, I will run through some drawbacks of convenient sampling and contrast with why probability-based sampling methods is preferred whenever possible. The sample consisted of county residents with ready access to Facebook and viewed the advertisements early. There was an overrepresentation of white women between the ages of 19 and 64, an underrepresentation of Hispanic and Asian populations. The sample preferentially consisted of people who were able to spare the time to drive to the testing site, which could skew the sample against essential workers, who we know are a vulnerable group when it comes to COVID-19. Additionally, homeless populations and nursing homes were not counted. In my review of the study, I did not see details with regards to the language that the advertisement was in, and if the language was predominantly or exclusively in English, we can also imagine how that might exclude certain populations as well, and populations that might also be at higher risk for COVID-19 infection. So again, we ask, how representative is the sample? And these are all issues that make us concerned about possible selection bias, or what we refer to in epidemiology as systematic error. In contrast, here are some benefits of probability-based sampling. With probability-based sampling, each member of the target population has a chance to be selected. Everyone has an equal or known probability of selection, which is important because this allows us to know exactly how we need to reweight the population if it's necessary in order to translate it back to the characteristics of the target population based on known probabilities of selection. Random sampling improves representativeness of the target population on both known and unknown characteristics. And if there are certain key members of the population or key subgroups within the population that we are concerned may have disproportionate exposure, we can also use methods like stratified and targeted sampling to ensure representation and analysis of all key subgroups. We should also be reminded that statistical inference assumes a random probability sample, both in terms of, or both with respect to how we calculate our bounds, our confidence intervals, as well as the statistical significance of our estimates. And finally, even when done perfectly, probability-based sampling doesn't guarantee us a perfect sample, and there is still room for random error. However, in contrast to selection bias or systematic error, random error is arguably easier to address and to improve upon by increasing the sample size, whereas it is much harder to correct for systematic error. Next slide, please. So at this point, you may still be wondering, how misleading is convenient sampling actually? After all, there were 3,300 participants. That seems like a sizable sample size, to which I refer you to an almost cautionary tale from world history. During World War II, the British Air Force planned to attach heavy plating to its airplanes to protect them from German fighter planes and land-based aircraft guns. The protective plates weighed too much to cover the entire plane, so the Royal Air Force collected data on the location of bullet and shrapnel holes on planes returning from bombing runs. Based on their data, they reasoned that they should position protective plates on the wings and the rear. Next, please. However, a Hungarian mathematician by the name of Abraham Wald realized that the sample was biased. The planes that returned could survive where they had been shot. It was better to add armor to the parts of the return planes where there were no bullet holes, because the planes that were hit in these locations were shot down and did not return to base. He therefore recommended adding armor to the engine, the cockpit, and the tail of the planes. And I bring up this historical example to illustrate selection bias and biased sampling, and to bring awareness to how thinking about the unobserved can change your understanding of the problem. And next, I will turn it over to Jean, who will discuss current or more recent seroprevalence studies. Thank you.
Thanks so much, Paul. So I'm going to be sharing some other examples of seroprevalence surveys from around the US. Here I'm starting off with New York, which completed the county's largest antibody survey as of May 2nd. They tested more than 15,000 adults total at grocery stores and community centers. So this is another example of what Dr. Wesson just described in terms of convenience samples. Governor Cuomo himself said during the press release, quote, "The surveys were collected at grocery stores, box stores, etc. That's important. It means you're testing people who, by definition, are out of the home and not at work. What does that mean? I don't know. But that has to be a factor that's taken into consideration." So the governor reported a prevalence for New York State of 12.3% and of New York City of approximately 20%. And there was a lot of variation throughout the state. So the Bronx had, which was the most heavily affected borough, had a prevalence of about 28%, whereas some regions upstate had a prevalence of less than 2%. And Black and Latino Hispanic populations had prevalences more than 2 to 3 times that of white populations and were disproportionately affected. In Los Angeles County, University of Southern California and the Department of Public Health are conducting a seroprevalence survey. Dr. Niraj Sood, the lead investigator at USC, graciously gave us some details on the study's sampling methodology. They plan to conduct testing every few weeks on a series of samples of adults who are randomly sampled from a market research firm database that has 2.4 million records from Los Angeles County. For reference, it has a population of about 10 million. They plan to set a target enrollment for each demographic group and close enrollment when a target is met. So to date, they've screened about 3,000 people. About 2,000 of those were invited to participate because their target demographic was not yet reached. 87% of those consented to participate. And of those, only about 51% actually got tested. So either people were unable to schedule a testing location in time, or they did not show for their scheduled appointment. The unweighted prevalence reported in the press release was 4.1%, which translated to an estimate of from about 220,000 to 440,000 people affected in the county. And the weighted prevalence Dr. Sood shared with us was 4.3%. He recognized that the sample may overrepresent people with symptoms, so they compared prevalence of symptoms in those that completed the survey but were not tested with those who were tested, and used this comparison to correct for bias. The unweighted prevalence was reduced by 0.1 to 0.4 percentage points after accounting for overrepresentation of symptoms. Finally, in Miami-Dade County, the county and its research partner, the University of Miami Miller School of Medicine, led another seroprevalence study in which they plan to test approximately 700 county residents weekly with the goal of serial testing to gain insight into how long antibodies persist. Dr. Aaron Kobitz, the PI at UMiami, kindly shared further details with us. They determined population density and socio-demographic composition of 32 municipal statistical areas in the county using census data, and then sampled those areas proportional to their population size, considering age, gender, and race ethnicity to ensure a representative sample. Florida Power and Light, the sole electricity provider in the state, generates random calls according to the target sample size for each statistical area. Those who answer the phone are consented, 95% of whom agree, and are surveyed by medical students. There are 10 testing sites throughout the county, and 85% of people who consented participated. The results available as of April 24th were for 2 consecutive weeks of testing. They reported a 6% prevalence both weeks and estimated that approximately 165 county residents were previously infected, accounting for the sensitivity and specificity of the test. They noted that African American and Caribbean communities may be twice as likely to be infected with COVID-19 as other racial groups. And Dr. Kobitz noted that they will be comparing those who are surveyed who do and do not get tested, but are unfortunately unable to compare those who do and do not answer their phones because Florida Power and Light is unable to provide that information. So as noted, when thinking about interpreting the results of all the studies that have been shared, there are two sources of uncertainty: sampling and measurement. And while the focus of Grand Rounds today is on sampling, we're going to take a short detour to talk about measurement because it's so important to the interpretation of these study results. I'm going to hand it off to Karen Byrne to talk about test accuracy.
Thank you, Jean. On March 16th, after much criticism in the media regarding inadequate test availability, the FDA lifted most regulatory requirements for COVID-19 test manufacturers to market in the United States. And this opened the floodgates. At that point, all a manufacturer had to do was to send a letter of intent to market and promise to provide the FDA their own validation data at some future date. By early April, there were more than 70 companies that had sent letters of intent for rapid antibody tests known as lateral flow assays. And that's what you see in this photograph. And there was a whole flurry of media coverage about the Wild West and unregulated tests. Next slide, please. So at that point, I was drawn into an effort to evaluate as many of these lateral flow assays, LFAs, as possible. They had been started by Alex Morrison and Patrick Hsu. And I was pulled in by Jeff Whitman, who's a clinical laboratory medicine specialist with whom I normally work on Chagas disease diagnostics. So we did the lab work for the first round of this from April 9th to 16th. And we tested 10 LFAs and 2 commercial ELISA kits, plus 1 in-house ELISA. One of the biggest challenges to this is getting enough specimens, and especially here where we haven't been that affected by COVID-19 yet. So we tested 130 specimens from 80 symptomatic COVID-19 patients, all of them RT-PCR confirmed, most of them hospitalized at San Francisco General. And because we know that you don't expect to have an antibody response immediately, we had specimens that covered a range of about the first month after onset of symptoms, and we analyzed by 5-day time intervals since onset. For specificity, we looked at 108 blood donor specimens from 2018 or earlier. And I should mention that we had a limit on the number of tests that we were able to obtain. And so that was one aspect of our, one limitation of the study. Next slide, please. The bottom line was that we found heterogeneous test performance. As expected, the rate of antibody response is low in the first week or two after onset of symptoms, but by 16 or more days after symptom onset, 75 to 90% of specimens were positive by essentially all of the tests, by either IgM or IgG. The median specificity based on our blood donor specimens was 95.5%, but it ranged from 84 to 100%. And there were 4 tests that had specificity lower than 90%. Next, please. So why do we care about this? I'm sure this is something all of you have looked at before. When we look at the performance of a test, we look at the sensitivity, or the percent with disease that are detected by the test, specificity, the percent without disease that are ruled out by the test. But we also generally look at predictive value, positive and negative. So positive predictive value is the proportion with a positive test who truly have disease. Or to put that another way, the proportion of your positives that are true positives. And for negative predictive value, it's the converse. Next, please. Why is this important? So let's take 3 of those surveys that Jean and Paul and Tom talked about. So Santa Clara County, 2% approximately prevalence. So for all of these, I've kept sensitivity at 99%. So this is actually better than most of our tests that we looked at. But I varied the specificity so that you can see the effect. So at 99% specificity, which is better than almost all of our tests. I think we had 2 tests that were 99 or greater. The positive predictive value would be 2/3, 67%. So 2/3 of your positives are true positives. If the specificity falls to 90%, then you have 5 times as many false positives as true positives. And your positive predictive value is less than 20%. At the other end of the spectrum, with the same test, with the same performance, in New York City with 20% prevalence, at 99% specificity, you've got this great positive predictive value of 95%. If it falls to 90%, you still have a positive predictive value of 2/3 and 67%. So how do you put this together? And then of course for Miami, it's in between. If the prevalence in the population that you're testing is less than 1 minus the specificity, then your false positive rate is likely to be higher than your true positive rate. In other words, if you have a specificity of 90% and your prevalence is below 10%, chances are you're going to have more false positives than true positives. One way to handle this, which is a common way to handle it, is to do a sensitive screening test followed by confirmatory testing. And this is what we do for Chagas disease, for example. The acceptable specificity for the screening test then depends on your tolerance for false positives, and probably your budget as well for the confirmatory testing. Next, please. So then we had intended to do another 20 of these LFAs, but on Monday, the sheriff and his deputy town. Next slide, please. So at the time we started the study, there were more than 70 intent to market letters on FDA's website, and there were exactly 2 authorized tests, 1 LFA and 1 laboratory developed ELISA. On May 4th, the FDA put forth new guidance, which basically walked back most of what they had done on March 16th. So no marketing without an emergency use authorization. And at that point, all of those 70, almost all of those 70 LFAs disappeared from their website. At this point, there are 3 LFAs authorized, 8 commercial ELISAs. These are on big platforms like Abbott and Roche, and 2 lab-developed ELISAs. So the entire landscape of testing changed in a matter of 6 weeks. At this point, I'm going to turn it over to Dr. Yehong Chen, and he's going to return to sampling issues.
Thank you, Dr. Warren. That was very helpful. Next slide, please. So I'll be talking about minimizing and acknowledging uncertainty from sampling. Next slide, please. So let's take a step back and let's imagine that we want to conduct a new study of Santa Clara. So our population of interest is Santa Clara residents. Our parameter of interest is the % of individuals with a history of infection. We're going to take a sample from the population because it is too difficult or expensive to obtain data from everybody in the population. And we're going to use data from the sample to estimate the parameter. And our hope in all of this is that the estimate is equal to the parameter. Next slide. In truth, it's rarely going to be the case that our estimate is going to be exactly equal to the parameter, regardless of how good our sampling is and regardless of how good the testing is. And what's worse is that we won't truly know how good our guess is, right? So the whole process involves uncertainty. So this all seems very scary and pessimistic, but here's some moments of optimism. So these 2 bullet points here, this is really what statistics is about. 1, we can try to acknowledge the uncertainty. And 2, I think really importantly, in the planning stage, we can try to minimize uncertainty. Next slide, please. And I'll be talking about ways we can acknowledge and minimize uncertainty from sampling. So when we talk about uncertainty from sampling, there's really 2 types to talk about. There's random error from sampling, and there's also systematic error from sampling. Next slide, please. So how can we minimize random error from sampling? So this happens in the planning stage. The most simple way to do this is to plan for larger sample sizes. But the relationship is not super simple. It also is helpful to sample people from diverse groups representing the natural variation in the population. I'll comment about this more later on. how can we acknowledge random error from sampling? So as many of you know, there are many approaches for doing this, confidence intervals, for example, and then keep in mind that these methods also take into account sample size because random error from sampling does depend on sample size. A little side note that Dr. Wesson actually commented on a little bit is that it's a little bit controversial to whether or not you can really describe random error from convenience samples. So I have a quote here from the late great David Freeman, who co-wrote the textbook that got me excited into statistics and epidemiology, which basically paraphrasing, he says that this is done all the time, but don't do it. And in fact, the Santa Clara does report confidence intervals, and one could ask whether or not that was legitimate given that it was a convenient sample. Okay, so what about systematic errors? Again, this is something we can do. We can try to minimize in the planning stage. And as I think Dr. Wesson laid out, the way we would try to do this is try to use a probability sample. Really the opposite of convenience sampling is what we mean by probability sampling. Next slide, please. Another really important way we can try to minimize uncertainty is to try to minimize non-participation. This is the idea that the people who participate in your study might end up being different from the ones who don't in really important ways. So certainly a question with all of these studies, I think, on coronavirus testing, because you might think that those who might truly have the disease are more likely to get tested. Okay, and now how can we acknowledge systematic error from sampling? This is hard, and Dr. Wesson touched on this, because I mean, we have mathematical ways to talk about this in theory, but once a study has been conducted, it's actually really hard to know whether or not we have systematic error. Because if you think about this, if you knew to do this, you would need to know what the value of the parameter is. And if you knew what the value of the parameter was, you wouldn't have conducted the study in the first place. So the best one can usually do is to rely on indirect checks. And Paul actually walked through some of that with the Santa Clara study. So for that reason, I really view systematic error from sampling as a hidden threat. Sample size is easy, but systematic error is really a hidden threat. And that's why I think it's really important that we begin by minimizing systematic error by trying to plan quote unquote good studies. Next slide, please. So on that note, I'll talk about a few sampling methods and try to show some relevance with studying coronavirus. Okay, so simple random sampling. So let's suppose, as I think many of you have heard, there's been many questions about whether or not children are more or less likely to transmit and so forth. So you might be interested in conducting a study to estimate prevalence among teachers. So we could do this. We could contact the school district and ask them for a roster of their teachers. And then we could randomly sample teachers from that roster. And this is simple random sampling. And next slide, thank you. This is very popular because it's very easy to understand and implement, but keep in mind that to do this, you need to have a sampling frame. You need to know, you need to have a list of people in your population. So stratified sampling. So let's return to this teacher example. So we might be worried, keep in mind sampling is random, right? So we could be really sort of unlucky, and when we do our teacher study, it could be the case that we just happen to select teachers who only teach small class sizes. And we might be worried about that because we might think that people who teach small classes might be less likely to have infection. So we can try to minimize this possibility by using stratified sampling. So we could divide the roster of teachers into groups defined by whether or not they're small class teachers or large class teachers, and then take a simple random sample from each group. What's really neat about this is that this will generally result in smaller random error from sampling compared to simple random sampling. And that's because we're taking advantage of the known variation in the population. This is what I referred to earlier when I was talking about ways of minimizing random error from sampling. Note though that you do need to know about, in this case, the class sizes in your sampling frame. Next slide. Okay, cluster sampling. As many of you know, there's been a lot of concern about the outbreaks occurring at nursing homes around the country. So we might be interested in conducting a study to estimate the prevalence of infection among nursing home residents. Well, unfortunately, there's no master list of nursing home residents, so we wouldn't be able to do a simple random sample or a stratified sample. But there are lists of nursing homes. Next slide. So what we can do is we can use our list of nursing homes and randomly sample nursing homes, and then collect data on the residents in the nursing homes. Usually, just for practicality, generally speaking, you would collect data from all the individuals in the sampled nursing homes. And this is cluster sampling. Cluster sampling usually results in larger random error from sampling compared to simple random sampling. And that's because individuals in the same cluster tend to be similar. So you're not necessarily getting that much more informative information. But it is a super attractive option when sampling frames aren't possible for the population itself. All right, complex sampling. So let's suppose that we want to do a new Santa Clara study. We might do something like this. We might sample census tracts from each zip code and then randomly sample households from each census tract and then recruit individuals from each household. So this is an example of complex sampling. It's basically a combination of the various approaches above and generally used for a combination of reasons of convenience and cost. Next slide, please. Now I'm going to talk about a different class of methods. These are newer methods, but still considered probability samples. Next slide, please. Next. All right, so there's also been concern about food delivery workers perhaps having a higher prevalence of infection. So we can consider doing a study of food delivery workers. Now, the companies that employ such workers presumably have rosters of their employees, but they might be unlikely to share these rosters with academic researchers. So what could we do? Well, one possible solution is to use something like respondent-driven sampling, which is a peer referral method. This would assume, though, that the food delivery workers are well networked. You may disagree or agree with that, but if you assume that they are, respondent-driven sampling might be a good solution. And the way this works is that the researchers purposefully select some initial participants. They then recruit their peers, who recruit more peers, and so forth. But all of this needs to be tracked. The recruitment needs to be tracked, and then generally speaking, the participants are asked to report about their network sizes. And the whole point of this is that is to enable calculation of the inclusion probabilities. Respondent-driven sampling usually results in larger random error from sampling compared to simple random sampling. All right, time location sampling. So now let's suppose that we want to study prevalence among supermarket shoppers, right? So maybe we're concerned about how dangerous it is to go out shopping for groceries. Now, companies have lists of shoppers to some extent via your discount cards, which track all your purchases and so forth, but these lists aren't fully complete. And as with the food delivery example, the companies probably wouldn't want to share them with us. So what could we do? Well, time location sampling is one solution here. So we could assemble a sampling frame of the supermarkets and the hours that they're open, randomly select supermarkets, randomly select hours from the selected supermarkets, and then randomly select shoppers. In fact, this seems to be roughly similar to what happened in New York, but the key difference here is that I think, at least for the media reports seem to suggest that the New York study is generalizable to the entire general population of New York, whereas it seems like the actual population that was being studied was shoppers. All right, next slide. So time location sampling might seem very similar to cluster sampling, and it is. A key difference, though, is that with time location sampling, you can't. With time location sampling, you can be sampled from more than one cluster. So with the shopping example, a shopper could be captured at more than one supermarket. Whereas in the nursing home example, generally speaking, you would say that you can only be sampled at one nursing home. And like respondent-driven sampling and time location sampling generally results in larger random error from sampling compared to simple random sampling. So hopefully I've brought you from a place of possible pessimism to optimism, and I think Dr. Clara will have, I think, a little more to share on that.
Wonderful. Thank you. Thank you, Dr. Shen. That was just terrific. So I am going to talk a little bit about can we learn anything from studies that are biased? We can go to the next slide. As Yang mentioned, it's extremely hard to do a perfect study. We're always going to be living with some imperfections in the extent to which the study sample accurately represents the target population. So what can we learn from the data that we have? We can go on to the next slide. The main question here is the extent to which the study sample, our little orange people here, I've superimposed the study sample, the population that we had a sampling frame for, and the target population in this image. The question is the extent to which the study sample really is similar to the people who didn't participate. The participants are similar to the people who didn't participate. And we're going to have to make some assumptions to learn much. So usually we can make very strong assumptions or very weak assumptions, and differing assumptions will deliver different bounds on our estimates of uncertainty. And the very weakest assumption we could say is, I don't know anything about the people who didn't participate. I have no idea. And very strong assumptions will give us more precise estimates, where we assume that the participants are just like the people who didn't participate. So we can really use information from the participants to tell us about the non-participants. Next slide. And what's probably more typical is something like what they've done in Santa Clara and other studies, where they're using post-stratification weights, where they say, we think that the people who did not participate are just like the people who did participate if we match on things like race and sex and other characteristics. So let's keep going. So let's think about, really walk through an example of how much we can learn from specific missingness and sets of assumptions. Suppose that we have a study in which 90% of people agree to participate and 10% of people don't agree. So if we have a target population of 1,000 individuals, we have 900 participants, and among those 90% who participate, we find a 5% positive test rate. So among the 1,000 originally in our target population, we have about 45 people who test 900 who participate, and of those 45 test positive. Well, what do we know about the 10% who refuse? If we make no assumptions, it's possible that all 10% are positive. And so that would mean that we have 100 new people with positive tests. Now, of course, we didn't get to test them, but that's the worst case, right? That means that we would actually have a prevalence of 14.5%. We put our 45 that we actually tested with our 100 we didn't test. So the max that we could possibly have in the population is 14.5%. But we also could suggest perhaps all of the people who did not participate would have tested negative had we been able to test them. If we use the same math, that comes up with a prevalence of 4.5%. So if we make no assumptions at all about the missingness in this setting where we had a 90% participation rate, we've got bounds, which are somewhere between 4.5% to 14.5%. Those are pretty wide, but we've learned something. So that's somewhat useful. Unfortunately, a 90% participation rate is probably higher than we can usually expect. And if we think about, for example, the Santa Clara study where they had a Facebook ad, it's hard to exactly calculate the participation rate with Facebook, but at best, it's probably around 7% after talking to the author's been really amazingly transparent. And so with their numbers, you can come up with the most optimistic number is about 7%. And honestly, that's probably pretty good for a Facebook ad. So if we only have a 7% participation rate, if we do that exact same math where we have a target population of 1,000, only 7% or 70 people participate, if we had the same calculation, we did this calculation, they had a 1.5% positive test. Now, if we say, okay, we don't know any, we're not going to make any assumptions about the 93% who refused to participate, actually our bounds are run from 0.1% to 93.1%. Really not useful at all. So to learn anything useful, we're going to need to make some more assumptions when we have realistic testing participation rates. Next slide. So let's walk through some examples of assumptions that we might be comfortable making, and realizing we just have to live with some assumptions. So the question is, are there any that make sense? And here I'm going to choose the example from LA because I think it's it will be more typical going forward about the participation rates that we see. So in the LA study, I think Jean showed numbers that indicated they had about a 44% participation rate. And they got an unweighted estimate of about 4.1%. So we know that the true test is lie somewhere between 0% and 100%. And if we make no assumptions at all, our actual bounds are about 1.8% to about 58%. So now let's think about, suppose that we're worried that we think, you know what, the people who participated might be healthier than the non-participants. And we think the people who participated would have a lower prevalence than non-participants. Okay, well, if you think that, we can narrow the bounds a little bit, because that means that at least that the population prevalence has to be at least what we saw in the participants. So now our bounds are 4.1% to 58%. Now, one thing you might think is, even if the non-participants oops. Okay. We might think that the prevalence among the non-participants is no higher than the prevalence among people who've actually tested in California as symptomatic cases. So if you just look at the something like 850,000 tests that have been done in California to date, only about 7% of those people tested positive. So those are people who, for the most part, thought that they were symptomatic, and still they only had a 7% prevalence. So if we assume that our missing 55% in the LA survey don't have any more than a 7.2% prevalence, that gives us bounds of about 1.8 to 5.7%. So that's actually gotten much narrower. Now we might imagine the opposite, that the non-participants have a lower prevalence than participants. So that would mean that if a person thinks they might be positive, they might be more likely to participate. That brings our bounds down to 1.8 to 4%. So that's actually pretty informative. And another piece of information that was really interesting from the Santa Clara study is that people who reported that they'd had cough or fever in the last 2 months had about a 50% higher relative probability of testing positive than people who did not report those symptoms. So even if you think that the participants are more likely to be positive because they think they've had symptoms, you might think, it's probably only going to be about 1.5 times as likely as the non-participants. If you're willing to make that assumption, you can bring the bounds down to about 3.3 to 4.1%, which we're starting to get really informative. The key insight here is that we can really narrow the bounds, even with imperfect study designs, if we're willing to make some assumptions. And what I think is really important right now about the unrolling of the COVID research is it's happening so fast that many of the studies can help one another. They can address the biases and develop complementary information. And I think this was raised by a couple of the questioners. Ali and Eduardo had asked questions that sort of indicate this idea that one study can offer insights that are relevant for another study. Now I want to move on to another idea from elsewhere in epidemiology that might be relevant for improving sampling understanding in COVID. And that's the idea that we could resample non-participants. So if we imagine a sample where 90% of people agree immediately, and we conceptualize those people as eager participants, but 10% did not agree to participate, we can go back to those 10% of non-participants and offer them extra incentives to participate. Either we can encourage them, we can tell them, we really need your information, we can try to reach them again. We could potentially offer financial incentives, or we could just make it much more convenient for them to participate. Instead of having drive-by settings, we can go to their house. And so we can get some of those people who initially refused to participate and consider these the reluctant participants. Now, it still may be that there's a substantial part of the population we never reached. In my little toy example here, 8% of the population was never tested, but we might be comfortable assuming that the non-participants are more similar to the reluctant participants, those people we resampled, than they are to the eager participants. And that can really give us information to more precisely estimate the population prevalence. And in this little toy example, we've got it down a little bit. You can go on next slide. We may even be comfortable saying, look, if the prevalence in the eager participants is higher than the prevalence in the reluctant participants, then we think the prevalence in the non-participants is even going to be less than that. And that really gives us a bound that's very useful on the overall population prevalence. This is very related to another idea, which is, next slide, the possibility of actually randomly assigning the intensity of recruitment. And just to walk through an example of this would be, for example, if you let me make an advertisement that we were going to put on Facebook. I am notoriously not visually inclined, as you may have noticed from the slides. And suppose that my wordy ad elicits a participation rate of only 30%. And then we hire a fabulous ad agency, which makes a beautiful advertisement, and they elicit a participation rate of about 90%. Well, what if being infected influences whether or not somebody participates, and this is a little directed acyclic graph for people who are DAGophiles. If being infected influences participation rate and which ad is randomly assigned also influences participation rate, we would expect an association between which ad the person saw and the prevalence of COVID. This is really powerful because it actually gives us a way to assess whether there's whether there's a strong selection bias. So we can know, because up to now we've had a lot of speculation about potential bias, but we don't know about the bias. This gives us a way to have more insight into whether there's bias. And with some additional assumptions, you can calculate prevalence if everyone had participated using this kind of design. This is, of course, totally feasible with Facebook or similar recruitment. We would likely randomly assign advertisements just to learn which recruitment ads work. And in some settings, for example, HIV, estimates of HIV prevalence in DHS, they've used other randomization, effectively randomized sources. For example, some randomly assigned recruiters might be more effective than other recruiters at eliciting enrollment. And you can use this exact same idea to assess the bias and understand, get an estimate of what the prevalence would be if we had full participation. So those are some ideas drawn from other areas that are potentially relevant for really bounding and improving our understanding in the context of imperfect data. And now I'm going to hand it over to Dr. Wesson, who has also got these very cool examples from other domains of epi that we're excited are potentially important. Okay, Dr. Wesson.
Thank you, Dr. Gleamore. While there are many challenges to studying COVID-19, many questions that remain unanswered, and at the same time, a lot of information released weekly and daily to try to make sense of, I think this presents an opportunity for us to reach into our respective corners of epidemiology and other disciplines to leverage the tools and techniques that have been developed to address similar challenges. In the next slides, I will briefly present on a couple methods we have drawn upon in HIV epidemiology that may be relevant. If we think about the challenge of estimating COVID-19 prevalence, including mild and asymptomatic cases, as analogous to enumerating a hidden or not fully observed population, capture-recapture or multiple systems estimation presents a potential solution. Next, please. In this method, this method estimates the total population size, or the total size of a population based on the overlap of at least 2 incomplete lists. And by incomplete, I just mean that the lists themselves are not a complete census of the population that is being studied. The list can take the form, can take a variety of forms, such as surveys, medical records, rosters, etc. But they must allow for the ability to match the same individual across multiple lists. We want to be able to say who is uniquely on list 1, who is uniquely on list 2, and who is on both lists. With several key assumptions, the intuition behind this method is that if there is very little overlap between the lists, then the unobserved population is likely much bigger than what was seen collectively on all the lists. Conversely, if there is a lot of overlap across the lists, then the unobserved population is probably not that much greater than what we had already observed. Next, please. We have used this method to estimate the number of people who fall into several vulnerable groups at risk for HIV acquisition, including men who have sex with men, female sex workers, and people who inject drugs. We also use this method to evaluate how complete a surveillance system actually is. And if enough information is collected, we can also perform subgroup analyses and try to answer the question if there are certain subgroups of the population that are systematically undercounted in the example of a surveillance system. This method is a great illustration of how the absence of evidence is not the evidence of absence, in that multiple incomplete data sources can be overlaid to paint a more complete picture of the distribution and magnitude of many different outcomes. Next, please. Another challenge we face in HIV epidemiology is how to reconcile multiple and sometimes divergent estimates of prevalence from different sources. My colleagues and I often confront this challenge when tasked with coming up with an estimate of the population size for men who have sex with men or female sex workers or other populations that are at higher risk for HIV acquisition using multiple different population size estimation methods. To make use of all the data that is available, I, along with Ali Mirzazadeh and William McFarland, developed the anchored multiplier, which is a tool to aggregate multiple estimates into a single consensus estimate. This is a Bayesian model that incorporates local knowledge or beliefs about prevalence, which is operationalized as a Bayesian prior, and combines it with each empirical estimate, which are weighted by the level of certainty around each estimate, such that the narrower the confidence interval, the more weight that is given to that estimate. This calculator is available for free of use on the Institute for Global Health Sciences website. And now I will turn it over to Dr. Morris, who will talk about current studies being proposed and being carried out here at UCSF. Thank you.
Thank you so much, Paul. And I just want to say how terrific it is for us to have the opportunity to not only discuss these featured research findings that are the early, I think, entree into what our seroprevalence studies are going to be coming out in the field, but I just wanted to take a quick snapshot at what's also happening here at UCSF. There are numerous community-based seroprevalence studies that are coming out. And let's just take a look at 7 to highlight the diversity of these samples. Next slide. I encourage you to reach out to the research teams with any questions that you might have, and perhaps by us featuring these 7 studies, we'll even have a follow-up grand rounds where we're able to have investigators present their findings of their studies. So this first slide demonstrates a study that was conducted in San Francisco community of the Mission District, and they targeted all residents, including essential workers. I think that this study, as well as the next slide, which was conducted in Bolinas, really demonstrate the value and the potential of conducting rigorous research within community settings. The study in Bolinas targeted all residents and essential workers as well. And I believe that these 2 studies the results are going to be shared at UCSF COVID-19 research sessions shortly if they haven't already. Next slide. Dr. Greenhouse and colleagues are conducting a 2-year study across multiple San Francisco communities using a sampling algorithm to select samples collected during inpatient and outpatient blood draws. So they're utilizing kind of a already existing platform of serologic samples in order to conduct this study. Next slide. Dr. Martin and colleagues are conducting a population study in regions on the east and west coast of the US, where they'll collect survey and venous blood samples from household members that are selected, or excuse me, sampled via probability-based methods. Next slide. As we know from attending other UCSF COVID-19 grand rounds and research sessions, Dr. George Rutherford has been very busy in this domain, and he and his team are carrying out several studies in relationship to understanding the incidence and prevalence of COVID-19. I'm just going to highlight 3 that are currently being rolled out. The first one is we'll conduct monthly PCR and antibody testing over 10 visits to determine the incidence of new infection and seroprevalence. And this is going to be conducted in 4 counties in the Bay Area using a stratified sampling method. Next slide. Another study by Dr. Rutherford's team also is being carried out in the Bay Area and will employ a different type of probability sampling frame to determine the incidence among targeted high-risk populations for COVID-19. And the last study by Dr. Rutherford's team is a multi-site collaboration of healthcare systems where they'll be targeting 3 hospital systems in order to assess COVID-19 seroprevalence. Next slide. So as we close the formal lecture of this session, I thought I'm an optimist. Most of my colleagues, nope, I'm going to say all of my colleagues are optimists as well. I think that as epidemiologists, you really do have to have a optimist kind of mindset to do this research. So let's consider the complete set of information within that lens. I think that we can think of this as being thoughtful consumers of these seroprevalence studies and the results that they are able to provide. And as Maria and others in this morning demonstrated, they can provide a foundation for us to apply lessons learned to subsequent research. And it is important when conducting both research as it relates to COVID-19 seroprevalence estimation, as well as any public health research, that measurement and sampling error can occur. And so you really need to consider this when interpreting findings and being able to understand when it can be, if it can be, and when it can be compared to generalized to other populations. All studies have implicit trade-offs. I think that we all experience that. There's always a balance between the amount of money you have, the amount of time you have, the amount of resources you have, and also the type of knowledge that you have on your team. But that this can also be complementary and that studies can be used together inherently. So we thought about different pooling exercises that perhaps we can also leverage as we start to see more and more research findings coming out across various subsamples. And so if we're thoughtful about how we do this research, it can be really transformative for the field of public health. So I want to say thank you all for your attention, and I want to just pass this back over to Dr. Bibbins-Domingo for her to close the session. Thank you.
Thank you, Megan, and thank you to all of the speakers. Those were really truly fantastic talks. I can't wait. I didn't know sampling could actually be so exciting. And I can't wait until the fall when we have our faculty, our staff, and our students joining us for a year-long series of talks to really increase our knowledge. I know that this sampling hub is going to focus on sampling hard-to-reach populations, on internal and external validity, which we talked about today, especially as they relate to pooled data sources, complex sampling designs for representative samples, and for techniques for estimating the dark figure. I'm sure you will get more word out to our community, and since we might continue to do this remotely, there will be a chance for many to join to gain from all of this knowledge. So we've gotten a lot of questions, and I'm going to try to get to as many as I can during this time period. I think some of the questions related to whether we actually learned something from these studies that were done, and what did we learn? And I think that several of you have addressed this. What I'd like you to ask about is as we go over time, and I think people can turn their videos on so that we can see all of our panelists. As we go over time and the prevalence continues to grow in the population, how do we learn from studies, not perfect studies that were done at this point in time, and the increasing prevalence as it goes on over time? How do we start to compare studies like that? Does anyone want to jump in?
So the question is, how do we compare evidence as it unfolds?
Yes, especially in an environment of active infection.
I mean, this is the reality that things are going to change, and that means that we just have to incorporate recognition of the fact that this is the facts on the ground are changing rapidly. So I don't think we would have an expectation that the numbers would be the same across waves of assessment. And George or others should jump in if there's a more formal. I mean, of course, we can model things formally, but the reality is they're going to change.
I think that's fair. It's this stuff is rolling, this stuff is rolling through the population. The numbers are going to change all the time. The trick is to separate the important stuff from all the junk. And I probably see 1,000 separate pieces of information a day, and to figure out the 10 to focus on is the trick. So right now I'm worried about schools and clusters in younger children, because that'll inform some of the back to school decisions, because a lot of the decisions about schools were based on an influenza A model, which says children that are a huge incubator of disease. That may or may not be the case here, and there's literature on both sides. So that's today's focus.
One of the things that I really wanted, one of the take homes that I really hope is that the science is happening so quickly, much more quickly than in most settings, that we can really build in new information in studies that are relevant to other studies, and take that forward, even as the prevalence changes over time. An understanding of the sorts of biases that we have to grapple with and what we actually have to be worried with can still be relevant.
And I think the field is hugely complicated by the use of preprints, which are, I never even knew they existed before this, just to give you an idea. And it's just, there's so much garbage circulating. And I mean, I would not only pay attention to the sampling methods, but I think you have to remember about Bayes' theorem, which is a relatively recent theorem in biostatistics. It's only been around since 1780. And it's because we're dealing with very small proportions here. And as Paul will tell you, when the true population prevalence is 0, every positive test is a false positive test, as we saw a very recent example of our cousins to the south.
Great. Can we talk, Karen, maybe you can also weigh in. We had questions about even the comparison test, the PCR test that you're comparing to in these antibody studies. And looking across multiple of these serology tests are comparing to, your hospitalized sample, but in one where you're doing both types of tests, how does the accuracy of the PCR test further complicate this?
Wow, there are about 10 questions there. We know that RT-PCR is not 100% sensitive. We know that its sensitivity changes with where the person is in the illness. It's highest probably from nasopharynx or oropharynx in the first week, and then it starts to fall. One of the reasons that we looked at time intervals is because we know we wouldn't expect to see antibodies in the first 5 days. We started to see a few. One of the wild cards that we still don't have enough data on, but we're starting to get some hints, is that people with milder disease seem to mount lower antibody responses than those with more severe disease. And I think that could be a wild card in terms of the question of doing population surveys where most of the people you're picking up were only mildly symptomatic. But I think we still don't have a good handle on that. And of course, that will feed into the question of which tests you use, because the big commercial ELISAs seem to be pretty highly sensitive. The LFAs are highly variable in terms of their sensitivity and specificity. So I really think that there is, especially in early days of doing these serosurveys, I really think that it would be a very good idea to do confirmatory testing, at least on a subsample. George, you want to weigh in?
Yes, you're right. We're doing confirmatory testing in our big studies. The UCSF one looks at the antibody to the nucleocapsid protein, the nuclear protein. The Stanford one looks at the binding domain, and we're switching positive specimens. So we're going to look at 2 different antibodies at 2 different sites on the organism. So I think that's one way.
Some negatives too. You're going to do a subsample of negatives also.
Yeah. We're going to do a subsample of negatives, so we know how to do this. Don't worry. But again,
so everybody's question is how do we get back to work, and how do large employers figure out how to use some of this scientific information to figure out what they do? Do you have any advice for the type of study that could be most informative, or how they make use of all of this information? Karen, you're shaking your head no.
No, I think the short answer is we don't know yet.
Uh-huh.
A positive antibody test means, and one of the hypotheses I've seen kicked around, but it's a pure hypothesis as far as I know. There's a little bit of data, is that perhaps people who have high IgG responses, which we know are not necessarily protected, perhaps those with high IgG responses will have higher titers of neutralizing antibodies than those with low titers of IgG. We don't know. It would be a useful thing to know the answer to that. And then we don't actually know, how well neutralizing antibodies by various different assays are going to with protective immunity. So we've got multiple steps before we can say this person has immunity, and even more steps before we get to the point of being able to say their immunity will last for 6 months or 2 years, whatever. George, I know you want to weigh in on this.
No, I don't care. Chris, let somebody else talk. I mean, I think the way the employers can use these data is to not pay any attention to them and ask somebody who actually understands them. There's so much partial information floating around and so many crazy ideas.
And so much misinterpretation of data.
Yeah, and sort of willingness to throw $1 million away.
Can I ask you to weigh in on, so what we know from the preliminary results from that mission survey is that focused on one census tract and getting probably about half of the census tract participating, although the census tract is 44% Latinx, it represents over 95% of the positive cases. And about 33% of the sample was white, and there were 0 positive cases there. And what we know is that there's quite an uneven distribution, obviously, even in this pandemic, of who actually is at risk. What is the best design to figure out in our area for what the true prevalence is, or the relevant prevalence in maybe higher risk populations? You can pick any one of this part of this question to answer.
I want to hear Yehang's view about this because I think he's got the most. But the one thing is to use stratified sampling, because when you think there's such different prevalences across different groups. But I'll let Yehang, who's thought about this deeply.
I mean, I think it's. I think it was great that we saw these community efforts, and I guess George could talk about the feasibility of doing this on a larger scale. But I think one thing to keep in mind with these community efforts is that there's always going to be people who don't participate, right? And so the sampling is always going to be relevant because there's always going to be non-participation. Yeah, as far as a design for this, I think something like some sort of complex sampling scheme seems good. You can certainly try stuff like phone, but my understanding is that tends to be really practically inefficient just because people don't pick up their phones. They didn't do it 20 years ago. They don't do it now with caller ID. So.
Great. Well, we've sort of reached the end of our time here. Does anyone have any final words or thoughts that they want to leave our audience with?
I just was noticing there was a lot of interest in how people can participate in the series and perhaps have a contribution to as we develop the content of the series for the Sampling Knowledge Hub. And they're welcome to email myself, Megan Morris at ucsf.edu, or our amazing PhD research staff member, Jean Digitali. And we're going to also include some information on our EpiBiostat website as well. So I just wanted to include that for discussion.
Yeah, and just to let you all know, in case you want to share these wonderful talks with your friends, there will be the video link will go out over Twitter. It's at the School of Medicine, has a YouTube channel that has lots of really informative talks, and this will add to our library there. I know many of you are watching on Facebook Live, and so there will be a link there. So many ways you can continue to rewatch these talks and continue to expand your knowledge of sampling. Thank you very much to all of the speakers, Megan, Karen, Maria, Paul, Yehang, Jean. Tom, and to George and to Jeff, who just joined us, and then particularly to Kemi and Cameron and Ben and Robert, who've really supported us in this work. Thank you all, much appreciated.
Thanks, Kirsten.